Okay, welcome everyone. Welcome to the KDIGO Kidney Health and COVID-19 webinar series. So today, we are going to have the first episode, Kidney Transplantation in Times of COVID-19. And it's organized with KDIGO together with Novartis. So although all of you know about KDIGO, I'm asked to at least give a brief summary of what KDIGO has been doing. I think all of you know that KDIGO stands for Kidney Disease Improving Global Outcome, and throughout the years has produced a large number of internationally acclaimed guidelines for nephrologists and also healthcare professionals around the world to use it. I myself have been participating in a lot of KDIGO events activities. I joined the KDIGO board of directors in the year 2006 and last for about 10 years. In the meantime, I have been doing the KDIGO GN guidelines, the live kidney transplantation guidelines. I also organized the XCV implementation summit last year. So there are a lot of activities I've been joining with KDIGO, and they have been doing a wonderful job. So as we are aware now, it's a very difficult times around the world with the COVID-19. So this time, we actually have a webinar series. I have two distinguished and renowned speakers from Singapore as well as from Sydney. So I'll first introduce Professor Steve Chapman, who is from Steve Chadban, Steve Chadban from Sydney. Professor Chapman is a director of renal medicine in the Royal Prince Alfred Hospital, Sydney, Australia. And he is also the professor of medicine in Kidney Hub CPC, University of Sydney. So he is going to discuss on the kidney transplantation COVID-19. So Steve, please.
Thanks very much for that kind introduction, Philip. I'd like to make some disclosures from the outset. Firstly, I'm not a virologist nor a transplant infectious diseases expert. Indeed, I don't have any current kidney transplant patients that I'm aware of that have been infected with COVID-19. Secondly, I'm not being paid to give this talk, but what I am is a practicing kidney transplant physician and researcher and a director of a renal unit that has made major preparations to manage the emergence of COVID in the general population. I'm also the co-chair of the Australian National Transplantation and Donation Rapid Response Task Force for COVID-19, and I'll talk some more to that shortly. I am a KDIGO guideline chair. However, this will not be a guideline talk. There is not enough evidence to do in this space to think of generating a guideline, and I wanted to make that clear. And finally, I wish to acknowledge some of my collaborators and the people who have provided information for this talk up front, particularly Jeremy Chapman, known to you all, Mark McDonald, a statistician with the Australian government, Stephen McDonald, the executive chair of ANZData, and Toby Coates, who's the current president of the Transplantation Society of Australia and New Zealand. I'd like to thank all of those people, plus my team. Kidney transplantation, I would like to follow this theme throughout the talk. Firstly, I'll talk a little about the virus. Secondly, about the clinical impact of the virus in kidney transplant recipients. Thirdly, about potential therapies, stressing the point that none at this point in time are proven. Fourthly, what we can think about with immunosuppression, but then mostly a focus on the epidemiology, viral spread, and strategies for control, and how we have attempted to do this from Australian context. And then I'd like to finish with some of the ethical and patient-centered implications of what we're doing in transplantation. So firstly, and I have to apologize for losing the color on this slide, but this is a heat map, which shows really that the SARS-CoV-2 virus that causes COVID-19 is a global phenomenon. It's a pandemic that has infected over 2 million people worldwide, causing 250,000 deaths. We understand that this is an RNA virus that is spread primarily through droplet spread, at least outside of hospitals, and via aerosolized particles in hospitals where we provide high flow oxygen or other procedures. It enters cells via the ACE2 protein, the protein well known to nephrologists. It is heavily expressed upon respiratory epithelial cells and enterocytes, and consequently focuses on detecting virus have been focused on secretions from these cell types. But as nephrologists, we understand that ACE2 is heavily expressed on endothelial cells throughout the body. And therefore, it should be no surprise to us that the manifestations of this infection include primarily respiratory problems, particularly pneumonitis, diarrhea relatively commonly, but in particular problems to do with coagulation occurring in multiple organ systems, including heart, brain, and kidney, coupled with an overwhelming inflammatory cytokine-mediated response. From the outset, we were concerned that our kidney transplant recipients being on immunosuppression would be at increased risk of severe disease from this virus. Whilst we were waiting for data to come out in kidney transplant populations, some data is emerging on other larger populations of immunosuppressed people. And here I present a recent case series from the New England Journal of Medicine of 86 consecutive patients with rheumatological conditions or inflammatory bowel disease for which they received biologics and or immunosuppressive drugs. And somewhat reassuringly from this case series, their manifestations and outcomes were very similar to that of the general population, such that 16% were hospitalised and no fatalities were reported at the time of this paper going to press. So some reassurance about a lack of impact of immunosuppression there. However, in complete contrast, last week we saw this publication from New York, again a case series, this time of 36 consecutive kidney transplant recipients in a major hospital in New York, the Montefiore Hospital. Here the patients were 42% Hispanic, 39% Black, ages ranging 32 through 77, 72% male, and a similar proportion had diabetes. And the vast majority were receiving tacrolimus, mycophenolate, and prednisolone-based immunosuppression following their kidney transplant. In this case series, however, presentations and outcomes were different to the general population. In essence, fever and other constitutional symptoms were less profound than for the general population. Lymphopenia and thrombocytopenia were very common, and in keeping with the modest symptoms, inflammatory markers were relatively modestly elevated compared to the general population. However, the outcomes were far worse. Here you can see that death occurred in 10 of 36 patients, representing 28% mortality. A high number required hospitalisation and intubation, 20% required renal replacement therapy. So, despite these bad outcomes, they occurred despite the institution of many and varied therapies, including attempts to block IL-6 cytokine transduction, high doses of steroids, antiviral drugs, and other strategies. Of particular note for kidney transplanters were two recent kidney transplant recipients transplanted within 5 weeks of presentation, both of whom had received thymoglobulin induction. Both of these were assessed as having very minor symptoms, suitable for home monitoring, but on follow-up, both patients perished. Severe outcomes. We have not only seen this from New York, but also similar case series from London, Spain, and Italy, again with no clear signal as to the efficacy of any treatment that was tried. Summarising the experience from New York all over, I'm grateful to Jeremy Chapman for providing this data from 11 of 12 major centres in New York, which really shows that that case report was a typical experience. Here you can see evidence of very large numbers of transplant recipients of all organs being infected with COVID-19, and that the mortality rates are up around the 15 to 20% mark. Severe outcomes indeed. I would stress that these are simply case reports from single centres and are not necessarily representative of the global experience. That global experience is being captured periodically by Transplantation, and I'd encourage you to go to the transplantjournal.com website to see global transplant activity updates on a regular basis. Now, some themes have emerged from this data. The case reports I've mentioned have come from high prevalence countries, and here I show a graph compiled using Johns Hopkins data but compiled by our government. It shows on the y-axis the number of active cases on a log scale, and on the x-axis the number of days since more than 100 cases in that country. What you can see here is that the case reports of severe and poor outcomes from kidney transplant recipients emanated from countries with high general population burdens of COVID-19, the US, Spain, Italy, and the UK also that I've not shown here. If I could contrast that with low prevalence countries, Australia, New Zealand, and South Korea in this instance, we can see that the general population prevalence is low and declining. Among our kidney transplant recipient populations, we've seen uncommon infection rates and good outcomes. For example, in Australia, where we have over 10,000 kidney transplant recipients, only 7 have been infected with COVID-19 according to an ANSData-conducted survey, and there have been no mortalities. So we here see diverging views as to whether you are living in a high prevalence, high problem area where you are likely to see a large number of patients infected and getting sick, compared to low prevalence areas where our incidence has been lower than the general population. We hypothesize, because we teach our kidney transplant recipients very well about how to exhibit good hand hygiene, about how to avoid crowds, and how to apply good social distancing. These are hypotheses only. Pharmacological management can be rationally thought of in terms of the biology of the virus, where we see that SARS-CoV-2 enters when the S protein engages its ligand, the ACE2 protein expressed on epithelial and endothelial cells, and together with a cell surface enzyme gains entry to the cell, releases its RNA, which is then replicated, ultimately to generate new viral particles, which are exocytosed with incurring cell death and generating inflammation. Strategies to block every step of this pathway have been attempted. Many clinical trials are underway. To suffice, no data has yet demonstrated efficacy in either prophylaxis or treatment of this infection. Several key hypotheses have likely been disproven, such that taking ACE inhibitors or ARBs may upregulate cell surface expression of ACE2 and thereby increase viral susceptibility. There is no evidence to support that strategy. Steroids, being anti-inflammatory agents to treat ARDS, have been trialled in high doses, and there is an emerging evidence that that may not be useful. Anticoagulation is being applied to manage procoagulant activities. The rapidly emerging data in global world interest has generated many calls to generate guidelines. These have been made to KDIGO. We have declined on the basis that there really is no evidence at this stage to underpin guidelines. Indeed, an NIH-sponsored effort, which I am showing here on guidelines for coronary disease management 2019, is shown here. And I think a very sensible summary of recommendations states that COVID-19 treatment guidelines panel does not recommend use of any agents for pre-exposure prophylaxis nor for post-exposure treatment of COVID-19. And indeed, they conclude that at present, no drug has been proven to be safe and effective for treating COVID-19. There are insufficient data to recommend either for or against the use of any antiviral or immunomodulatory therapy in patients with COVID-19 at any stage of the illness. And that, I think, is the extent of the data. So if we have no proven therapies, what can we as clinicians do? Leading the response against this virus is a key thing we can do, and my colleague Vathsala is going to talk about her efforts in this regard in Singapore very shortly. Much literature has emerged speaking of the role of clinicians in leadership. This is one paper from the New England Journal last week, which looked at 7 platforms that a clinician can lead. Assessing capacity in the hospital with the competing requirements for general healthcare versus need for COVID-specific management. Analytics to look at data as it emerges. Ethics, which should override all of our should guide all of our clinical decision making. Science innovation, as we see much data emerging in terms of treatment and management of this. All of this feeding in through to clinical standards, communication and teamwork, coupled with personality characteristics of resilience in very challenging times. Against that platform, I'd like to describe what we have done in Australia and New Zealand in an attempt to respond to this crisis from a transplantation perspective. Around 8 weeks ago now, we formed a transplantation and donation COVID-19 rapid response task force under the combined auspices of the Transplantation Society of Australia and New Zealand, coupled with the Donate Life and Organ and Tissue Authority of Australia, to get lead clinicians together from transplantation, from ICU donation sectors, from infectious diseases, and data analysts, all representing the key bodies involved in this clinical situation. We meet bi-weekly Zoom meetings, which will occur in 2 hours from now, and we undertook to provide a communique to all TSANZ members and other relevant parties the very next day, and that has continued. Our clinical leads then disseminate widely through their co-workers and administrators so that all of the hospitals and clinicians are together on this. We have ensured government engagement at all levels, both federal and state. And furthermore, in the last 5 weeks, we've produced a digest targeting patients so that we can keep our patients updated and provided website videos. To give an example of our strategy, by the 3rd meeting, which was on March 24, in Australia, we had rapidly escalated to over 300 cases per day, and very few at that stage had resolved. There was clear evidence of spread within the general population. All hospitals were beginning to prepare for a surge in activity, and all public health strategies had been activated, including social distancing, hand hygiene, and cessation of school activities. At that meeting, we we reviewed the data, and we agreed, shall I go forward? One try. At that meeting, we reviewed the global prevalence and outcomes data for the general and transplant populations and discussed them along with local projections. We established that donor requirements for ICU resources in an increasingly constrained environment were a problem. The projected increases in COVID-19 positive patients within hospitals and in the general community would thereby increase the risk of both nosocomial and community infection of donors and recipients. Recipient requirements for ICU resources, particularly for non-kidney transplants, would be a problem in its environment. That recipient risks of COVID-19 infection during a highly immunosuppressed post-operative period with frequent hospital clinics would be a problem. And that recipient risks without transplantation for at least 4 months should be evaluated to determine the pros and cons of proceeding to transplantation at an individual level. We considered logistic constraints related to COVID-19 testing of both donors and recipients in this environment, and considered also the impact of the virus on transportation of surgical retrieval teams, organs, and recipients. And our recommendation at that stage was to suspend kidney transplantation completely, living donors and deceased donor programs. That kidney pancreas would also be suspended, but that heart, liver, lung, pediatric and multi-organ transplant program should continue, restricting to only ideal donors, providing organs for people who were deemed to have a survival of less than 4 months without transplantation. All of the above measures were broadly agreed upon and were undertaken subject to weekly review. From a donation perspective, we continued to support donors whilst ever capacity existed within intensive care units, but with a focus on higher quality donors only. Against that background, our government and public health strategies yielded major reductions in the number of active cases. Here, the histogram on the left shows the cumulative number of positive diagnoses in the blue curve compared to the number of recovered cases in the green curve, with the bars showing the number of active cases. And you can see that as this number diminished substantially by the middle of April, we started to discuss a resumption of kidney transplantation activity, and we have effectively resumed in all states apart from Victoria as of today. I would stress that this is not a simple process. Stopping transplantation, it turns out, is much easier than restarting. Each state is likely to move towards usual activity in a slightly different fashion and time frame due to local logistics and requirements. Many factors need to be considered prior to recommencing transplantation, including implications of transplantation with massively reduced commercial flights and other logistic issues, tissue typing laboratories and allocation processes that have been put on hold, hospitals and local area health positions with redeployment of staff to COVID-centred activities, same for organ donation staff. The final point we realised was that patients are at the end of all of this, and clear communication and a lack of ambiguity was the key to explaining the situation to patients. Therefore, we've decided to restart kidneys as we believe the balance has flipped in favour of transplantation for patients over remaining on dialysis. But even having done this, we realise key challenges that lie ahead. From a general population perspective, we have a virus that has a high proportion of asymptomatic carriers. Indeed, up to 50% of people will swab positive before exhibiting any symptoms. We understand that this virus, when coughed onto surfaces, particularly plastic and stainless steel, may remain viable for many days, thereby yielding its high infectivity. And as mentioned, we have no drugs and no vaccines as yet. Thus, there is high risk of more infections in the community. Hospital dynamics have changed enormously. There's been massive redeployment of staff, resources and wards to COVID-19 based care. Topping this, we have fatigue, a lack of leave, loss of travel and other challenges that staff are facing at an individual level. At a community perspective, we're about to go through a relaxation of social distancing, a return to work and school, plus slowly increased travel. This, coupled with a fatiguing public and medical response and mounting cost pressures, do increase the risk of a population-based resurgence of disease. From a transplantation perspective, what does this mean? It means that with an asymptomatic, pre-symptomatic carriage of viruses, we may have difficulty ensuring that our donors and recipients are indeed not infected. We've elected to go with pre-transplant testing of donors in all cases. For recipients of deceased donors, we have elected to go by history and examination and where time permits testing, but we understand this will not be test positive in every case. The likelihood of transmission of this virus from an infected donor to recipient is uncertain. There have been cases documented. How frequent that will be remains to be seen. And finally, the utility of serology in enhancing this decision remains uncertain. Secondly, we face challenges in hospital dynamics with redeployment of staff, resources and wards to and from COVID-19. We now have less space for donors and recipients in ICUs. Thus, we anticipate a reduction in donor rates. We have less staff available. And of course, we have a risk of resurgence. We have no treatment available for our cases who acquire COVID-19 post-transplant other than judicious reduction in immunosuppression. Thus, this creates uncertainty for patients and their carers. I'd like to close there, but would like to touch on two new issues in closing. Firstly, to remember the ethical issues involved here. As clinicians, we wish to do good, we wish to avoid harm. We need to acknowledge the competition for resources in treating competing priorities, being COVID-19 versus transplantation. And Peter Stock and others have recently written to the effect of this in transplantation, as evident here. I'd encourage you to read this paper. And finally, there is a patient perspective to this, and I'd like to thank Alison Tong for leading a group who's currently doing patient workshops to determine what the patient perspective is here, what all this means to patients. And I think that will be equally as important as our other issues. At that stage, Philip, I'd like to close. Thank you.
Sure. Good afternoon, everyone. And it's a pleasure and an honor to be here and sitting next to or socially distanced from Steve Chadban to give this presentation. But I'd like to start off by thanking KDIGO and Novartis for having me at this presentation. And certainly these are very unprecedented times. And what I'm here to do today is to really give a very practical talk on how we have been approaching it at the National University Center for Organ Transplantation. And I hope that this will be of benefit to the audience here. And certainly, at this point in time, I would like to declare that I too am not an ID physician. I have no knowledge of epidemiology, but I have a great deal of resources in this institution to support us in our care for our transplant patients. I think just moving ahead into the presentation directly, I think we all realize that this is an epidemic or a pandemic that we had never dreamt of would be upon us when we woke up on New Year's Day, a mere 100 plus, 5 months ago, clearly. And this has been such a startling experience for all of us at a personal level, at a professional level. And as we sit today, we have over 3.58 million individuals actually reported to be infected with COVID and over 250,000 deaths. That is overwhelming in terms of the tragedy that has befallen this world. But we have a special mission, and what I suppose our mission is about is what is the duty of care that we have for patients who are transplanted, who are candidates for transplantation, and that's where this particular presentation is going to be. And there will be many people in the audience who have transplant centers that manage large groups of transplant patients, or an individual nephrologist or a hepatologist who is managing their own transplant service, so to speak, so in the community. But if you take the perspective from what Steve has shared, it is obvious that patients with kidney disease, and this is from Kidney International, which there's been data to show that those with underlying kidney disease, whether it is just proteinuria or an impaired creatinine, impaired renal function, they do have a higher risk for mortality with COVID. I think the other issue is what Steve has highlighted. Many centers have reported really adverse outcomes. This is just one series from Spain with a high population incidence of COVID, where the mortality was in that publication in April, earlier in the month, the mortality was 27.8%. So given that, I think it really behooves us, the transplant professionals, to find a strategy to take care of our prevalent transplant populations and even for planning for transplantation for those who are candidates. Now, I'm coming from a Singapore perspective. I think you all realize that Singapore is a very small country, but we do have an organizational system of how we approach any kind of an infectious emergency. And if you see this slide here, you will see that that there is different levels of population risk. For example, those where there's lower incidences in the community, then there will be a yellow alert. But as the increase in prevalence of a particular disease goes up, it goes into an orange kind of a phase of response, and this is called a disease outbreak response system that we have in Singapore. So with this kind of a background that exists in Singapore, you will if you can note on the next slide, the first case in Singapore was documented as confirmed as COVID positive on the 23rd of January, and we moved into yellow alert on the very next day. Then subsequently, the number of cases rose. We had our first access to the PCR for routine clinical care actually very early, and I think that's something remarkable that we have experienced in Singapore. By the 4th of February, we had access to PCR assays for patients to be tested under various environments in the hospital. And then, but unfortunately, we then, with the increasing cases in the community, even though they were in the double digits, or so to speak, we moved into what is called DORSCON orange very early, by the 7th of February, actually. And we started using social distancing, masks in the hospital systems, and many measures came into place. But I think we're all social animals, and whether or not social distancing is practiced to the rigorous measure that we want it to be, we know that's not a reality. And then we had returning, as the global outbreak grew, we had returning members of the community who came back from overseas, brought with them several infections. So as you can see in this chart, we've had an increase in the community, so to speak, from overseas returnees. And then by April the 7th, we moved into what was known as a circuit breaker measure. It's not what is a total lockdown, but nevertheless, it was a measure implemented by the government to have most people stay at home unless it's essential workers. But soon after that, we started our next outbreak among dorm workers, or people who are foreign workers who lived in the dorm. So as you can see, the numbers have grown dramatically in this graph. And now, as of today, we have over 18,000 infected individuals. Thankfully, the large proportion of them are well, and very few have been in the ICU, and we've had very few deaths to date, mainly in the elderly population. But nevertheless, Singapore is still in the growing phase of infections. While it is a secluded infection in certain communities, it nevertheless requires us to have had different responses at different phases of our increase in the community of COVID cases. So the current slide that you should be seeing is just a description of our transplant program in Singapore, where we have two major transplant centers, and the transplant center that I'm representing is the National University Center for Organ Transplant. Are you all seeing my slides? Is there a problem with seeing the slides? Can somebody indicate to me if there's any problem with the seeing of the slides? If there isn't, I'm just going to continue. We have over 1,700 patients that we follow up in our transplant center, and we at any point in time do about 80 new transplants a year. So in looking at the principles of how we manage our transplant population, we looked at what we needed to do to ensure that we have a duty of care to our patient population. One is, so to move on, we collaborated with our ID consultants and our epidemiology in the hospital, and so that we could stay one step ahead of the situation and exercise a higher level of safety and precaution for our transplant population in comparison to that of the general population. We calibrated our strategy to community and individual risk, so to speak, and we wanted to be proactive rather than reactive in our approach to patients. And our goals were mainly, the key principles was to educate our staff as well as our patients how to manage our transplant population. And as you look at the next chart, as you can see that with increasing population risk or numbers of patients, we calibrated our care in a similar manner. Okay, so what are the usual goals of care, and what were the goals of care? I think the usual goals of care for our prevalent patients is, of course, to maintain their graft status, to prevent mortality, to prevent and treat graft rejection if it were to occur during this time, prevent and treat infection, prevent hospitalizations, and ensure timely access to emergent care, because we realize that many of our patients did not want to come into hospital during this situation, and we needed to ensure that they did understand that they have timely access to emergent care, and we wanted to facilitate their entrance to hospital, and we want to optimize hospitalization outcomes. And we ensure that our patients have an adequate supply of immunosuppressants and other medications to treat their comorbidities. On top of this, we know that there are candidates who are awaiting transplantation. We didn't want them to die on the wait list. And we, at the same time, want to ensure that we have no wastage of precious organs at this very difficult time. And we remain committed to the care of COVID-infected patients and also prevent COVID pandemic among transplant patients in the community, in the clinics or in the ward, and of course to preserve the much needed resources for those in need. So it was a balance that we needed to take into account. In terms of our considerations for our staff, we educated all of them and made sure that they had resources. For example, that they needed to, if they had thermometers, social distancing, they practiced it themselves, they recorded their temperatures. This is actually mandated in the hospital that we record our temperatures twice a day and submit it to a website. We communicate the principles and the reasons behind our strategy. We make sure that they have the adequate equipment, thermometers, masks, and hand sanitizers, so to speak. We keep working on staff morale, as Steve has mentioned earlier. And this applies, the staff. Who are our staff? Our staff are everyone, including doctors, coordinators, nurses, administrators, cleaners, pharmacists. And I think the family grows larger. Many of them were afraid. Some of them were separated from their families because they actually live elsewhere and work in Singapore. And during this period, they have had to continue to live in Singapore. And they have roommates maybe who come back infected, or their family members who are on home quarantine or stay at home, what to do. And then, of course, many of the food and beverage outlets are closed. How do they get food when food is not great? How do they manage? How do they be happy? None of them have had vacation leave, really. So this is working 24/7. And then we have had many of staff being absent because we split our teams. Our teams immediately after COVID came into existence. We split our teams into the inpatient and the outpatient teams, and the inpatient teams are not supposed to see outpatients face to face. And then we've ended up having many staff go on leave because of their own illness, intercurrent illnesses, or their family members being quarantined or having stay-at-home rules been applied to them. Embracing change, I think, has been an important fundamental for how we keep everyone working in this COVID pandemic. And it's tough to get change working from home, often not an option for many staff who are working frontline and dealing with patients. We have to redesign jobs. So we have actually held our living donor workup. So people who used to do living donor workups have had their jobs redesigned, and they have to learn how to manage clinical patients. We've adapted smart ways of doing our work. For example, we do video consults and telephone consults, and I'll touch upon that a bit later. But essentially, what this slide shows is what were the practices that we were practicing at yellow when COVID first began entering the shores of Singapore. And this was around January 24th. And then on February 7th, we moved into DORSCON orange. And you can see right away we had a plan. On the January the 30th, we had a plan that we have actually stood by since then, because we knew what we should do when the numbers got worse. And all we have done since January 30th is to tweak a little bit of how we do things rather than the plan that we set into place during that window of opportunity that we had between the 24th of January till the 30th when we instituted this plan. So we said, okay, when the numbers grew, we will stop our living donor transplants, we will stop our disease donor high-risk transplants, we will stop managing our donors, we'll stop doing living donor workups. So we had a plan in action starting around January 30th, which we communicated to our teams, and we had a standby plan as to what we would do when we moved into DORSCON Red as well. So we've had this plan since about January 30th, and that has kind of helped stand by us since then over the next 3 months, because with this plan, we've been able to just move from light orange to deep orange as we speak. And this has allowed us to kind of institute changes rather rapidly. So what I hope to do in the next few minutes is to just share what our effective plans have been. So the first thing we did was to separate our inpatient and outpatient teams. So the inpatient team is not allowed to see outpatients. And I think there have been a center, for example, in Tasmania, which has had a hospital outbreak and has also decided that this is a very important measure, because those who manage inpatient transplant recipients should not manage outpatient transplant recipients, and we've kept that going since January 30th actually. And each of our teams are separate. Our inpatient ward is segregated. Even from within the ward, we've separated our own transplant patients from the others, and we have signages everywhere to ensure that everybody knows who is in the transplant side and who isn't. And we rotate our teams so that everybody is not tired. In terms of what we do for our outpatients, even for our inpatients to continue, every EMD admission is, for example, triage for an acute respiratory illness or fever, and if they have, or for a contact history, and if they are triaged to be at risk for any of these, they go to an isolated ward outside of UCOT. If they've had 2 swabs that are negative, then we de-isolate them and move them into the UCOT ward, only if the 2 swabs are negative. And we've had a response time and a turnaround time, thankfully, of about 12 hours or so to get our swab results out. For patients who develop fever within our UCOT ward, we have a philosophy that we wear masks when we see them, but if they turn febrile, we will do 2 swabs for them and adopt full PPE, so to speak, and then de-isolate them only if the 2 PPEs turn out to be negative. And this is the same principle that we adopt for patients who are transferred over from other hospitals, for example, for the urgent liver transplant, so to speak. So if somebody is a COVID positive, we will not take them back into our ward. They will be de-isolated even after their PCR negative ×2 into a non-UCOT ward, because the robustness of the negativity is at this point in time unknown. So in terms of what we have done for our outpatients, historically, I think you all will realize that, I think we do a technical visit, and then they get their blood test done. And then if the blood test can be just looked at by a coordinator with the doctor's advice, we would do that. That's what we call a technical visit. Or we would do a clinic visit with the results available. What we have now adopted in DORSCON Yellow, at least since starting from January, is that every patient is actually triaged before they even enter to get our UCOT clinic to get their technical visit done. So basically, they are triaged for symptoms, they're triaged for their contact history, and if they have a high-risk profile, so to speak, that means they had gone overseas historically, or they had fever, they wouldn't enter our normal clinic. They would enter a special care clinic, or if they have upper respiratory tract symptoms, they would be sent to the emergency department as needed. So we've had this triaging that has been instituted, and that has allowed to focus our resources and manage our patients in a very stratified manner. So in addition to triaging, the coordinators will decide upon their action as to, do they go to a special care clinic, or do they go to EMD, or do they need to go to a high-risk clinic even within UCOT. so that we can stratify our care and our personal protection for the staff based on which clinic they enter. For example, it's a normal care clinic, we could just see them with a surgical mask. But on the other hand, if they were to be seen at either a special care or a high-risk clinic, we would don our full PPE with a gown and gloves before we see them, and doff them in an appropriate manner, and there'll be appropriate cleaning of the premises based on what kind of a patient it was. So as I alluded to earlier, our strategy has been to stratify our patients from the very beginning. And as an overall overarching strategy, we monitor what is the community spread of COVID and try to keep up to date with our Ministry of Health advisories on the clusters. We anticipate potential risks, for example, patients traveling or our staff traveling. We would collate, our administrator is very key to this, collate the list of clusters so that she would prepare a list of questions that the coordinators would then ask for each patient before they enter. And I'll touch upon this in a while. So we would have one common script for all the coordinators to practice, and we refresh the script on a 2-weekly basis based on what's happening in the community. And our senior coordinators would transmit messages from the manager and the staff meeting, which is also done by video consult, by the way, for any of the changes to be disseminated to the rest of the team. And this is an important strategy for doctors, the administrators, the nurses, and the coordinators to take upon themselves to hold these, say, 2-weekly or 4-weekly meetings so that you can have a strategy and we have that implemented across the board. We also developed a database so that we know what was the date of the transplant. Are these patients who are less than 6 months or over 6 months, are they stable? Do we know their creatinines, for example? Do we know whether or not their recent rejections? So we keep this as a live database, so to speak, and determine whether or not what is the clinic capacity based on where we are. So, and we update the database on a regular basis so that we know which patients can be seen and which ones should be seen on an emergent basis. So, for example, this was kind of our clinic profile in January or early February. We would segregate, for example, the high-risk travel patients who had travel exposure to a particular time of the day, a particular time of the week, and we'd do terminal cleaning for the whole clinic if we are seeing those patients. The rest of the week, we could see normal cases, which is shown in green, and there's no need for any special measure other than, say, just area cleaning, which could take less than 5 minutes. And then if you saw special cases, who had fever due to other causes, we would also institute some special care at the end of the clinic for that particular room. So as you can see in the next slide, our triage script is very structured, and we would go through how are you feeling. The coordinators do the bulk of this work, and I really want to thank all our coordinators for having been so rigorous with this, because they do this a week or two before the planned visit. Even if it's just a technical visit for a blood draw, they will ask them about fever, whether they've had exposure to the various clusters, whether they've traveled anywhere, whether they have any contact history with the various groups of people, and then they'll take the necessary action, triage them to the appropriate clinic. And sometimes we have to repeat this. Example, as we moved with greater community spread, we have to re-triage them at day -3, or so to speak, before they enter the clinic again. So we did have a very structured questionnaire that all our coordinators would use, and our administrator would come up with this on a regular basis, keeping in pace with what's actually happening in the community. For the next slide, it's a rather animated, complex slide. I hope you all can see it. But basically, there's a triage prior to the clinic visit, and then there's a triage on site. And if, again, the patient manifests any symptoms, they'll be ushered off to a special care clinic. But if they're otherwise well, they will move on to get their blood draw. And if that's the end of it and that's a technical visit, they go home, wait for the next clinic visit, which will be also conducted on site. And this was what we used to do in yellow, so to speak. And at that time, they'd come back And at the clinic visit, we do social distancing. Only alternate seats are occupied, as you can see. Everybody wears a mask, including the pharmacist, and we keep our distances from everyone. And as you can see from the next slide, maybe there's a bit of a lag. It's not moving along. Someone can help me with that. I believe it's a bit of a lag on the slides. Aaron, if you would like to look in on the animation, it's not moving, I think. Okay, so I see that now. So as you can see, I think there is a bit of a lag on the slides that you see, but I hope you will get the full imagery of it as time goes along. And if I click often enough, hopefully the slide will appear animated as it is supposed to. So as you can see, there's a special area that has been cordoned off if you want to see special care patients. And everybody practices social distancing, whether it is in the clinic or, for example, in dispensing advice. And with this, I think we managed quite a bit. We managed to, as I will share with you a bit later, we managed quite a bit of our patient load, and we didn't need to change our philosophy of care. As you can see, as we moved into deeper orange, we needed to expand our clinic scope to be able to see more patients. And if you have practiced so much social distancing and so many triage steps, not everybody can get a face-to-face visit. So what we incorporated is adding in more technical visits to our consults, and more phone visits as well. So as we moved into deeper orange, and I'll share this with you in the next slide. As you can see, the patient still gets the same amount of care. There's again a bit of a lag in the slides, I think, but hopefully you will get to see this over time. But okay, there you go. You should be seeing this where the technical consults would lead us to a different way of doing things. For example, we would do more remote or contactless counseling. We would put in home delivery of medications, and even the payments were just billed to the home so that the patient would have no encounter with healthcare staff as things progressed. We instituted video visits as well, whereas the patient would come to the clinic and then would do the video with the inpatient doctor doing the video with them, with the patient being in the outpatient setting. This allowed us to see more and more patients, and I'll share the actual numbers with you in a while as to how we managed our workload by incorporating a series of technical visits, telephone consults, as well as video consults, and therefore that would help us to manage an increasing patient workload, which I hope you'll catch up with soon in the slides. So I'm going to skip by the next slide, and I hope you can see the way we do a face-to-face consult combined with a blood draw. And again, it's done with as much social distancing as possible, where the patient comes in, a lot of triage takes place, and the patient consults with the physician in as safe a manner. We try to limit contact time between physician and the healthcare provider to less than 20 minutes, so as to limit any exposure to infection from the patient. If they happen to be infected, we still arrange for home delivery of medications. We still arrange for counseling by the coordinator, counseling by the pharmacist, and continuing with home billing. So with these measures, we've actually managed a very significant workload. And with this workload, you can see that we have evolved in practice. Instead of doing face-to-face consult for the majority of our patients, we've been able to do video consulting, and we've been able to do a phone consult, and we've actually been able to manage more than 70% of our workload with a series of these measures. I again apologize, and I regret that the animation is not keeping up with my current content of the slides, but having said that, I think it's a bit of a lag, and this is the problem with the internet. I think we all need to learn how to work with internet and other new devices. And this we all need to get smarter, and our internet connections need to get a lot smarter as well. So I think we'll move on to the next phase of what I wanted to do to discuss, which is what about the candidates who are awaiting transplantation? Do we want to get started with our program? So this particular slide that you have in front of you is a discussion on some of the key issues that we have with resumption of transplantation. Okay. So I think the resources are limited. Wards and ICUs are full. Elective surgeries in our hospital are largely cancelled. So would a straightforward transplant actually allow access to dialysis? Because that too is going to be limited. But how about for acute liver failure? Isn't a transplant a life-saving procedure? So one of the questions is, are there adequate resources for the transplant at that transplant center? Is there bed availability? Is there blood availability? Because remember, many of our blood donors cannot go to the blood banks if there is a lockdown. Is there operating theater availability? Are our resources really stretched? Are our surgeons available? Our surgeons are actually, some of them are in the dorms helping swab workers at this current moment. Do we have enough supplies? For example, are there radiopharmaceuticals? And for a MAC3, for example, that has to fly in from somewhere. We don't make them in Singapore. So in our principles, our key principles were that we would not want to take an organ from an infected donor, so we'd have to exclude somebody who's a COVID positive. We want to choose our recipients carefully, and they should be a low immunological risk patient. We don't have plasma exchange available 24/7 at this point in time. Blood products are a scarce resource, and we want to maximize or minimize post-operative complications. So these were our considerations when we came together with our plan in January. And it really is increasing pre-transplant immunosuppression a potential risk. And as you heard from Steve, it is a risk. So in our discussion, we said, okay, we will plan for some transplants, but look at our resource availability. So when it came forward during our planning stages, we said, okay, we'll let our donors and recipients know if they are living donors that they will not travel, right, prior to for 21 days prior to the actual transplant that was planned. And at that time, we said we will tell them 21 days is the limit as to when they can travel. The other thing that we said is we're going to do the swabs for them starting from day -7. We'll do one swab at day -7 and another swab at day -2, and have both of these to be negative before we actually do the proposed transplant. So this was our plan. In reality, what we did with the growing numbers in the community is we didn't do any living donor transplants once we moved into deeper and deeper orange. And we said we have now adopted a policy where we will do a living donor transplant only for liver transplant, and that too if the patient had a high MELD score or was in acute liver failure. In terms of disease donor transplantation, our policy that we set into place way back in January was that, for the disease donor transplant, we worked with the Ministry of Health, and under the guidelines of the Ministry of Health held their transplant advice And I recommended that we don't do any disease urgent unless they were really, really urgent. So we didn't do any disease donor transplants until much later. And so this was also it was not until about April they gave us the release to do some disease donor transplants. And so we have resumed disease donor transplant. We do screen our disease donors 3 times actually, as mandated by ministry, before we would proceed. And we'd also do a single screen for our recipient before we proceed with a disease donor transplant. And so I'm happy to share that we would do a disease donor transplant only if all the conditions are met. That means it's a low immunological risk transplant who's not likely to get into an ABMR, because we don't think plex or blood product availability is an option. We wouldn't do it for a positive PRA. We would not do anybody who's extremely extended criteria, and no biopsies would be done as an explant. We do screen our recipients universal. They need to be negative before we do the transplant. So we've had a very successful cooperation with our laboratory facilities, because it's say, oh, I only have one more assay, I can squeeze that in for y'all. And so we did do our first disease donor transplant during this COVID time on April the 15th, and all 3 were successful. So it was 1 liver and 2 kidneys. So we've been very happy. So I just wanted to conclude and summarize in the next slide that with the growing numbers of patients, we've adopted increasing measures. And I think every center does have to have a plan and to put into place, depending on what the community risk is. We stratified our clinics, we stratified our services, we triage very extensively. And because we've done that, we've been able to maintain our load of at least 70% of our patients being seen. And I'd like to think that if you have a plan in place, we will overcome some of the risks that happen to our patients. And I think this is very, very important as we move forward in the plan. I want to share this little, so I think this is a global survey that was commissioned by the Bill Melinda Gates Foundation, which suggested that the US and the UK were the most prepared for an infective outbreak. But unfortunately, I think no matter what you are or where you are, it doesn't mean that you're really prepared, because I think only when the situation comes and when the situation is upon us, we should put in measures into place to ensure that we are prepared. So we need to ensure that in a situation where elective surgeries are canceled, whether or not we are really, really ready, totally depends on where your team is, and having a triage system, having your coordinators work with you, and your nurses, your administrators, your entire team work with you, ensures that patient care can be implemented for the large proportion of prevalent patients for whom we have a duty of care. With that, I thank you.
Okay, so we thank both Dr. Chapman and also Dr. Vathsala for the very nice talk. I also declare that I do not receive any pay for moderating this session. I would like to start with some questions. Many of you have already written some questions to us. I'd like to ask Steve. Some of the audience have asked how to manage the immunosuppressive therapy for the recipient with COVID-19. So, Steve, would you like to say something on that?
Philip, I think there is no clear answer to that. A number of guidelines have suggested different strategies around the world, and a number of the more severely affected units have released case reports where some centres stopped all immunosuppression and gave maintenance steroids only, others reduced calcineurin inhibitors, and others reduced anti-proliferative drugs. And really the outcomes have been similar for all. I don't think there is a clear message. I think that people who are sick and in intensive care do need less immunosuppression than others, but how that is done really remains up to individual clinicians. My personal bias is to reduce CNI exposure and to reduce mycophenolate dose or eliminate it if someone is severely sick, and potentially increase the steroids a little. that's opinion only, I would stress.
Vathsala, do you have any points to add on this?
We've had only experience with one COVID transplant patient, and what we have done for that patient is to reduce the mycophenolate and to reduce the CNI. For that patient, he was also on Calitra, so we had to reduce the CNI significantly. And we managed to clear him of his, well, he's still PCR positive, but he's cleared of the symptoms and he is well. So we've had a good outcome with our experience by reducing mycophenolate and moderating CNI levels. Yes.
Okay, thank you. My second question, maybe the both of you, is that one audience asks, what would be the strategy for any donor found COVID positive during donor evaluation? Would the transplant be postponed, and until when should it be postponed? Vathsala?
We would reject that donor. Our present plan is if it's a living donor, we would reevaluate that donor in 3 months' time and see if they're really cleared. We would refer our potential donor to an ID physician who would evaluate with repeat COVID swabs as part of the evaluation, and then only we would proceed if the COVID swabs are negative on 2 occasions. So this is our present plan in place.
Steve?
I completely agree with Vathsala's plan. From a deceased donor's perspective, we would not work up any donors who were suspected to have COVID-related illness as part of their terminal illness. We are screening potential deceased donors who do not have the COVID-related illness on clinical grounds, and we would not proceed with any donor in that context who tested positive.
Okay. Probably my last question is probably apply to both. It's very similar to the last one, but one of the audience asks, what's Australia's policy for dialysis patients on waitlist who are tested positive for COVID-19? Are they suspended? If so, for how long? And what's the criteria for reactivation on waitlist? So, Steve?
I think that's an excellent question. One of our great fears in suspending deceased donor transplantation was that we would see an outbreak in a dialysis facility, as has been reported in China and in other parts of the world. Fortunately, touch wood, we have not seen that to date. Our strategy would be that anybody who is waitlisted and has an illness consistent with COVID and or a positive test would be suspended from the active waiting list for at least a month until at least a couple of negative tests. It would be nice in that context to know what serology means and to have reliable tests for serology so that we could demonstrate immunity, but I'm afraid that we do not have that level of reassurance at this stage for clinical purposes.
Right. Maybe Vathsala for Singapore?
Exactly the same. That is that we would actually extend the wait for 3 months. As you all are aware, there is no currently available antibody assay that is robust enough to confirm a response. And we must also recall that our patients, our dialysis patients, are all also immunocompromised. We have also not had any epidemic or within our dialysis centers, but we have had a few smattering dialysis patients who have had COVID infections, but we do not put them back on the list at least a minimum of 3 months. And our own center response would be to have a repeat swab, say 3 months later. And if that is negative, then place them back on the list. And this will be the case, I think, until we get an antibody that's reliable enough to be used to confirm and response to the infection from the patient. Yes.
Right. So I think that we have a very good talk.
What's your philosophy?
Sorry.
What's your plan in Hong Kong, Philip?
Well, Hong Kong, we actually have stopped the elective live donor transplantation since January. But then we did not stop the cadaveric transplantation. And since January till now, we have 18 cadaveric transplantations done for kidney. But the question is for the waiting list for dialysis patient. Well, touch wood, luckily, up till now in Hong Kong, we do not have any dialysis patients who contracted COVID-19. So we don't face such a question, which is quite difficult. I agree with both of you. The antibody testing at the moment is still not confirmatory of what does it mean. So at the moment, I think that if they are really COVID positive dialysis patients, I think we would not put them on the waiting list at least for another 2 to 3 months as suggested by you, and then wait for more scientific data about the antibody testing before we know what to do with them. But we don't have the live experience because luckily we did not have any dialysis patients who had COVID-19. So I think we already 10 minutes overrun. There are a lot of good questions, but unfortunately, I don't think we have enough time to go through many of them. So on behalf of KDIGO, I would thank the both speakers for the excellent talk, and I also thank all the participants who have been listening. So with that, I would like to conclude the session. Steve or Vathsala, you have any last words you want to say?
Thanks very much for your attention.
Yeah, so thank you, and I want to again thank Steve and Vathsala. So we'll conclude this session. Thank you.